this allows for passive descent of the baby. It lets the contractions move the baby down further, okay, depending on what the fetal station is. So again, just because mom's 10 centimeters doesn't mean she has to start pushing. If she's 10 centimeters and she's comfortable and she doesn't feel the urge to push and baby's happy, contractions are going and she's got a good epidural, just let the contractions do some work, okay? Because once she starts pushing, you know, she could be pushing for a while. There's usually limits on how long they can push. Okay, providing encouragement, again, cheerleader at the bedside. You may have to help kind of guide her into relaxation also. Relax your shoulders, you're doing great. All these supportive things. Support the partner. Okay, make sure they take breaks, make sure they eat, make sure they rest. We have 2 patients already, we don't need a 3rd one if they decide to pass out because they also haven't eaten in 24 hours. Okay? All right, we're going to go straight to this slide here for our stages and phases of labor. So first we're going to look at the different stages of labor. Okay, the first stage of labor is all of labor. It's dilation and effacement. Okay, so how long does labor last? Well, when did it start? When did I get to 10 centimeters? That's the first stage of labor. And that can be hours. The second stage of labor is basically how long did I push? Okay, so from the time we're 10 centimeters and we start pushing to the time the baby's delivered. That is the second stage of labor. The third stage of labor is how long after my baby was born was the placenta delivered? Okay, and that could be anywhere from 5 minutes to 30 minutes. Okay. These are important to know because, well, you might see it on a test, but also there's limits on how long we want moms pushing for. And, you know, we want to know when to expect that placenta. Okay. It should be delivered, shouldn't take too long. 30 minutes is kind of like the max. Usually it comes out pretty quickly. Within the first stage of labor, all of the labor and contractions and dilation, there are 3 different phases. Okay? The latent phase is like early labor, from 1 to 4 centimeters. Moms are usually pretty chatty. They like distractions. You know, things haven't gotten that bad yet. The active phase is when they might request their epidural. It's from 4 to 7 centimeters roughly. They get a little bit more, oh my gosh, this is actually happening. Enter the zone during the active phase. And then transition, 7 to 10 centimeters. This is where you may find them yelling at their partner, saying, "You did this to me, get out of here. I don't want to look at you." Get a little bit more restless. So these are things, this is where it's kind of good to know what happens in each phase because you can recognize some of those behavior changes, right? If you have a mom that's all of a sudden very irritable and doesn't want anybody touching with her, like she might be in transition, that baby might be coming sooner than you think. Okay, so each phase, first, and then the first stage, second stage, and third stage. There is a 4th stage also, and that's the recovery period. We'll talk about that at some point as well. I think it's in this chapter. All right. Vaginal, any questions on the stages and phases of labor first? No? Okay. Vaginal birth after a C-section, also called a VBAC. This happens if you have a successful vaginal delivery after having had a C-section. If you've had a C-section, you get to have what is called a TOLAC, a trial of labor after cesarean. Okay, you get to try labor. If you are successful, then you've had a VBAC. All right, these are case by case. The concern is that that area on the uterus where the incision was made could rupture open. Okay, did I show you guys how they do this? I don't know. So when they do a C-section, when they do a C-section, it's your first C-section, so they make the incision on the uterus, right? And they sew everything back together nice after the baby's born. When you have a second C-section, they don't just cut this line, they cut just above it, they cut just below it. They have to cut out that scar tissue, and then they sew this back together. Next C-section, just above, just below, sew it back together. So every C-section you have, they have to stretch that tissue a little bit more, right? This area gets very thin. The more you have, the thinner and the weaker it gets. So that's the concern, is that when you start having contractions with a future pregnancy, this area is very weak and could just break open, rupture open. So one C-section is fine, not a big concern, but that's why after 2 or 3 or 4, it's not ideal to try and have a vaginal delivery. And we'll talk more about this in, I think it's in chapter 8. Because the type of incision that you have is also going to be a factor in whether or not you're even a candidate for a trial of labor. Okay. Anybody who's had a previous C-section should have any future kids. You had 3 C-sections?
Mm-hmm.
You cannot have any vaginal delivery.
Yeah, no.
I had 4, and my last one was breech, and they're like, oh, she's breech, right? I'm like, does it matter? Like, it was a resident that I didn't like. I was like, does it matter? Like, she's only coming out one way.
Yeah, my last child was the only one that put me into labor, and they still had me go through labor. I'm like, why are you making me go through this when you're gonna
There's
cut me
some
open?
discussion about after 2 C-sections, if you could have a successful VBAC after 2
They
C-sections.
told me no. They told me no. They said straight up that if I wanted that, I had to go to New Haven. And I said, well, I'm not doing that. So I'm in Bridgeport. And they're like, oh, let me check out, see if you're dilated. Why? I am not pushing.
Like,
Just-
not interested, right? Just take
cut
me back.
open already.
Take me to the back. Well, that's the thing. If you've had C-sections, you should not have a home birth after, or even a birthing center. You should deliver someplace where there's a surgical team that can intervene, because if that uterus ruptures open, you have minutes to get the baby out. So you want to make sure you're someplace where it can happen in minutes, if needed. All right, nursing responsibilities at delivery. You get to do it all. Okay, they have, most labor and delivery units, they have all of these carts are prepared and ready to go. They have all the instruments that you need, everything that you need for the delivery on a cart. It's covered with a sterile drape, and they just wheel it into the room when it's time for the baby to be born. Perineal scrub, administering meds to the mom or baby, providing initial care to the infant. Not only do you get to take care of mom, you get to take care of baby too. Although there's usually several people there. Evaluating the APGAR score, which we'll talk about in a minute. Examining the placenta. You can look at it if you want, but the doctors are going to want to look at it themselves and make sure that the whole placenta is there. Checking the baby for obvious abnormalities. Making a note if the infant has a stool or urinates. We'll go through each one of these. Identifying mom and baby with bands, and promoting bonding. Okay. So in our 3rd stage of labor, is from the time the baby's born to the time the placenta is delivered. So it's delivery of the placenta. This is the maternal side here. Okay. This is the fetal side. You can see the umbilical cord coming out of the center. You know, the provider is going to want to look at it themselves. They want to make sure that the whole thing's there and that no pieces were left inside, which could cause further problems for mom. So they're going to examine it. Some moms want to see their placenta, whatever you want to do. But they look at it. Does it look normal? Does the cord look normal? Is the cord coming out of the center? All that stuff. If there's concern, sometimes they'll send them to pathology to be tested. But the placenta is examined. In our 4th stage of labor for mom, this is our recovery stage. Our biggest concern right after the baby's born is making sure that mom's bleeding is under control. So we want to evaluate for hemorrhage. We want to make sure she has bladder function and urine output. We're evaluating recovery from anesthesia, providing that initial care to the baby, and promoting bonding. So observing for hemorrhage. Vital signs are going to tell us a lot. Okay. Remember, tachycardia is going to be one of our first signs of maternal hemorrhage. Heart starts to beat faster. Skin color, pale, clammy. Location and firmness of the uterine fundus, which is not going to make a whole lot of sense now because we haven't talked that much about it, but the fundus, the top of the uterus, right, this rounded part, should be, after the baby's born, you should be able to palpate it in the center of the abdomen, right around the belly button. That's where you'll feel the fundus if you palpate mom's abdomen. And we'll look at that when we talk about what happens postpartum, because that's how we evaluate recoveries, the descent, is that fundus shrinking back down. Lochia is postpartum bleeding. We'll talk more about that in chapter 9, okay? And pain. Keeping her comfortable, keep her warm and dry, make sure we change any of the pads that are underneath her so that they're not, wet or damp. That can promote bacterial growth. Ice. You guys ever heard the song Ice Ice Baby?
Mm-hmm.
Baby ice ice. Okay, when that baby's out, ice. Give her ice ice. Ice helps, with swelling. It helps with bruising. It helps with pain. Think about if you ever have a toddler running around and they whack their head on the corner of something. What do? You give them ice. An ice pack, because otherwise you get this big, usually get a big egg anyway, but ice helps decrease swelling, helps with pain, helps with bruising. All right, so observing for hemorrhage on the mom. Again, we're going to evaluate the uterine fundus, the firmness, height in relation to the belly button, and position. We're going to evaluate bleeding. The bleeding should be dark red with no more than 1 pad saturated per hour, no huge clots. Okay. A continuous trickle of bright red blood means that something is actively bleeding, and that would be a laceration somewhere, and we will talk more about that in chapter 10. All right. Observing for bladder distension. Remember, she may not sense that her bladder is full. Okay. She doesn't have the weight of the baby sitting on her bladder anymore. She may have had an epidural, so she might have full sensation in her lower half. So we want to make sure that that bladder is empty, because that can cause more problems postpartum as well. If she's not able to get up and void, she needs to be straight capped. Or if she's not able to use a bedpan either, then straight capped. All right, care for the newborn. We have 3 different phases. So we're going to talk right now, phase 1, which is right after the baby's born. And then in the future chapters, we'll talk about, an hour to 3 hours after they're born, and then later on, once they go to the nursery. If there's no issues with mom and or baby, they stay together. There's no reason to separate them, unless there's a medical reason. Priorities for infant. Keep them warm, maintain cardiorespiratory function, observing for urination and passage of meconium, identification, make sure we identify mom, baby, and newborn. Mom, dad, and newborn. Mom, baby, and newborn. Perform a brief assessment for major anomalies and encourage bonding and breastfeeding. So maintaining temperature, it probably seems kind of silly, right? But cold babies are prone to respiratory distress, and they're also prone to blood sugar. So keeping them warm is a very simple thing to do that can prevent from recurring. They have been floating around in mom's belly for 9 months. Mom's body temperature is probably 97 degrees. Right? When they're born, they are wet, and they are entering a room that's at best probably 70 degrees. If not colder, because mom's been in labor and has been working and that, it's a hospital, so it's gonna be a little bit cooler, and she's probably got fans blowing on her and everything. So that baby's temp can go down south really fast, okay, because they're small, they're wet, and they've abruptly entered a much colder environment than they're used to, okay? So keep them warm, it's very simple, okay? After we know that they're breathing and they're crying and their airway is good, we're drying them off, putting them skin to skin with mom, putting them under a warmer if we're not able to put them skin to skin, just to keep them warm. They put a hat on their head, they lose a lot of heat through their heads, they put a hat on. Maintaining cardiorespiratory function right after they're born, sometimes before their whole body is even delivered. The provider will suction out their mouth and nose with a bulb syringe. Have you guys seen a bulb syringe? Usually you squeeze them, stick them in their cheek, suctions out everything in their mouth, and then suction out their nose. Usually once the head is out, they'll take a towel and they'll wipe their face off right off the bat before their whole body's even out. So, and then we make sure they have a good airway. If they're crying, they're breathing, they're perfusing, it's going to start working the way it's supposed to work on the outside. Everything's going to switch from that fetal circulation to normal circulation like we have. Okay. Cord is clamped and cut. This used to be done pretty quickly after the baby's born. Now they wait a little bit, at least 60 seconds we try and wait before we clamp and cut the cord. Okay. There's extra stores that come from the placenta to the baby, so they try and hold off for at least 60 seconds before they clamp and cut. Spontaneous breathing usually begins within a few seconds. They are blue when they're born, but they should pink up quickly, except for their hands and feet. Acrocyanosis is a bluish color of the baby's hands and feet. It's very normal. Okay? It does not mean that they are cold. It doesn't mean that they're in any respiratory distress. It's just that perfusion is very slow in the beginning, and the palms of their hands, the soles of their feet can have a bluish tint tone to them for 24 to 48 hours after they're born. Okay, so definitely normal. Signs of respiratory distress include persistent cyanosis other than the hands and feet. So if the baby has circumoral cyanosis, like around their mouth, if their whole torso area looks a little pale or dusky, that's concerning. But hands and feet, not a big deal. Grunting respirations, nasal flaring, retractions, we'll watch a video in a second. A normal respiratory rate for a newborn is 30 to 60. So if they're tachypnic with a respiratory rate over 60, that is respiratory distress. Our book says Narcan should be kept on hand in case it's respiratory depression that's caused by something we gave the mom. But give it to the baby and put them into like an instant withdrawal. So if the baby has respiratory depression due to, maybe we gave mom a dose of morphine too close to delivery, they would probably opt to just support the baby until the medication's out of their system. So maybe the baby needs to be put on a ventilator for a couple hours until the medication is gone, rather than give them Narcan, which could make them withdraw right away. Oh, I don't see the verify. There is our baby in respiratory distress. So you can see the retractions right here. And then you hear that sound? That's grunting. As he exhales, you can hear that grunting noise. That's another sign of respiratory distress. So somebody should give him some CPAP. Help him out. Cancel. I don't know what all these Their videos are good.
My cousin was doing that there. Shania's one, I just seen
Alright, I don't want something else to start playing, which I'm sure it will. So if they have respiratory distress, you know, we'll treat that with whatever is helpful for that baby. It might be, like I said, some CPAP, it might be a little bit of oxygen. If they're not doing well with that, then they might need to be intubated and put on a ventilator for a little while. APGAR scores. You guys heard of APGAR scores? It's like their grade, like how well they did being born. Okay? APGAR score looks at baby's heart rate, their respiratory effort, muscle tone, reflex response to suction or stimulation, meaning if you suction out their mouth or you bother them, are they mad at you? Or do they care? And skin color. APGAR scores do not have anything to do with what kind of genius your child is going to be, okay? Although a low APGAR score could, if they have several low APGAR scores, then that could be like oxygen deprivation, which could lead to some issues down the road. But all the APGAR score is looking at is how well did they go from being on the inside to being on the outside. Okay. At every delivery, there should be somebody there that can care for and tend to the baby if there's an emergency. Okay. Ideally, they come out and they just start crying, but not all the time. They don't always do that. So we have to be ready in case they don't. So the baby's going to get a 0, a 1, or a 2 in each one of these sections. And don't worry, I'm not going to ask you to figure out the APGAR score of an infant on a test question, okay? It's just nice to know. You should know kind of the values. So anything over 7 is good. Right? Anything over 7 means the baby did great going from the inside to the outside. So they get a 0, 1, or a 2 for each one of these sections. And it, basically for activity, are they active? Are they moving around? 2 points. What's their heart rate? Is it over 100? Another 2 points. Okay. Depending on what each section is, what it adds up to, they get their APGAR score. Nobody really gets a 10 because they all lose a point here because they all have that adverse diagnosis. This is done at 1 minute of life, and then it's done again at 5 minutes of life. And if both of those are not great, they'll do another one at 7 minutes and then potentially 10 minutes. We will keep going. There are guidelines in the hospital that they cannot leave the delivery room until their APGAR score is a certain number. So if it's a very premature baby or a very sick baby, like you can't even bring the kid back to the NICU, we have to stay in until we get the APGAR score at a certain number, okay, because they're not stable enough to move. Identification, okay, wristbands, we have wristbands with printed numbers, numbers and letters usually come as a set. There are 2 bands. There are 2 adult bands, one for mom and one for whoever mom wants to have the second one, okay? It could be a spouse, it could be an auntie, it could be a grandma. If she does not want anybody to have the second band, it goes in a sharps container, okay? Because we don't want anybody pulling it out of the garbage and trying to take a baby. Okay? So it gets discarded where it cannot be retrieved. We check those numbers every single time the baby is taken and brought back to the mom. And I always joke around that even I took care of my nephew when he was born, and I took him out of my sister's room to bring him to the nursery for something, and when I brought him back in, I checked their bands. Like my own nephew and my own sister, because it's so ingrained in your head if you work in that environment to check the bands. So it didn't matter that it was literally like my family. I was like, no, let me see your band. I have to check the band. That's the way we identify and match mom to baby, right? So that you don't want to bring the wrong baby to the wrong mother. There are bands that have security chips embedded in them. They're like little tracking devices for the baby, meaning if the baby is brought near a door or an elevator, an alarm will go off. The unit is locked down, security is notified, the whole hospital is locked down. If somebody cuts the band off, same thing happens. Okay, so I can't can't even remember the last time I read about a baby being abducted from the hospital because we have so many measures in place now to prevent that from happening. If you notice, you can't just walk onto a labor and delivery floor, right? Like if you go to Bridgeport Hospital and you want to visit grandpa on the 10th floor in the cardiac unit, you can just get off the 10th floor and walk onto the cardiac unit. But any unit that has a child, that has children or infants is locked and you have to be let in. And if for some reason the unit's not locked, like I think St. V's is not locked, but you can't even push that button on the elevator without a special badge or card. So, you know, there's definitely extra security measures in place. And we have footprint sheets so that matches the baby's just in case. So that's what these all look like. Right. It's hard to step here, but these are the bands. So these two wide ones are the adult bands, and there's two thinner are the baby bands. And there's usually 5 numbers and 3 letters, and you match them all. Make sure they match with mom and whoever else has the other band. Footprint sheet looks like this. Okay. This is the security band. This one is on the ankle, like a little ankle bracelet. But they do have some that are a part of the cord clamp, so they clamp onto the baby's umbilical cord. Those aren't as, well, no, I guess because they'd have to cut it off anyway in order to leave with the baby. I think the ankle ones are more common. Observing for urinary function. Meconium. If that baby pees or poops at all, even if it's just a little dribble of pee, it would be nice to document that. Okay? They can't go home from the hospital until we know both tracks work and both tracks are open. So if they have meconium in their amniotic fluid, does that count as poop? Sure. Yeah. All we really want to know is, does it work? Is the hole open? So any stool, any little bit of pee, document it because you don't want to hold up their discharge when this time it's like he hasn't peed, but in the meantime the baby peed all over the doctor when they were first born and nobody documented it. Okay, bonding, as soon as they're dry, warm, and stable, wrap them up or place skin to skin with the mom for bonding. There is nothing that emergent that needs to be done, especially during that first hour, which is also called the golden hour. We just let everybody kind of get to know each other. Okay? They don't need their whole head to toe assessment in that first hour. They don't need their medications that most babies get. That can wait. As long as they're breathing okay and they're stable, let them stay with mom undisturbed. Okay, medications that are administered after that initial hour, we can take them and do an evaluation and also give them their medication. There are 2 meds that every baby in the hospital gets. Okay. Vitamin K, which is an IM injection. It is given in the outer thigh, in the vastus lateralis, and vitamin K helps with blood clotting. They're deficient in vitamin K, bless you.
Thank you.
So they need that vitamin K to help with clotting. They also get erythromycin eye ointment, much like the silver nitrate in the baby's eyes from chapter 1. Okay, it just prevents any transfer of bacteria from causing any problems. If the parents do not want these, they simply say, no thank you, and we just chart that it was not done and the parents refused. Okay. The doctors can talk to them about vitamin K if there's a concern. A lot of them, providers won't do a circumcision if the baby hasn't had vitamin K. So, you can take those cases as they come. But those are the 2 meds. There's a third one that a lot of hospitals are now starting to give, but it's not one of these are the 2 standards, okay? Hep B is the other one, the first hepatitis B vaccine. A lot of those are getting given in the hospital now, but it's not an official, one of the official medications that they have to have, or that are standard right after they're born. All right, observing for major anomalies. There's going to be certain things that you will see right away. If baby has a foot, you're going to notice that. If spina bifida, you're going to notice that. Those things are also usually diagnosed before the baby's even born. So, if they've had regular prenatal care. You may see a small puncture wound on the scalp. if they have internal monitoring. We're looking at, are they moving symmetrically? Okay, if they had forceps for their delivery, they could have some paralysis of their face, which we'll get into in chapter 8. If their shoulder got stuck and they had a little shoulder dystocia, that could cause damage to the clavicle, which would mean they're not moving an arm all the way. So we're looking, are they moving symmetrically? Does their mouth move symmetrically? Fingers and toes are counted and checked for numbers. Number 1, do they have extra digits? Do they have webbing in their digits? We'll look at pictures here. Okay. So here's from an internal monitor that looks kind of infected. They don't usually look that bad. This baby had forceps. You can see the forceps line there. But where the forceps are placed sometimes can cause damage to the nerve in their face. It goes away on its own. There's nothing you need to do for it, but we would want to know if that was the case. This baby webbing, you could miss this. This is not that noticeable, especially on their tiny little toes. This one you would definitely notice, the webbing of the fingers. This baby, this could be club foot. It could be positional. You know, the docs can evaluate that. Some of the things to look for. Cleft lip, cleft palate. A cleft palate you may not see because that's up on the hard palate of the mouth. You may not see that right off the bat. We'll talk about all of these in chapter 14. It's fine a bit for that. Okay, cord blood banking. Okay, there's different types of cord blood banks. There's public banks and there's family banks. With public cord blood banking is basically free to store the cord blood, but it's not just yours. It's anybody that needs it can use it. As opposed to private or family banks, you pay for it, but it's only for you, for your use or your family's use. The hospitals do not just have kits available usually. If you want to bank your baby's cord blood, you have to go there with all the things to do so. They'll collect it, they'll send it out because it has to be sent out pretty quickly, but you have to prepare for it. At least to my knowledge, they don't have any just standard kits laying around to collect cord blood. All right, but cord blood's good for stem cell therapy, things like that. The microbiomes during labor and delivery. Microbiota are a community of organisms that are in every human body. There are some thoughts and discussions about how the type of delivery interventions that are done during delivery can affect the transfer of those microbiomes and long-term effects like immune system and gut function of infants. So let me go to the next one. Things that enhance the transfer of microbiomes from mom to the would be labor. That's it. I think that's our longest chapter, and we all made it. You survived. Chapter 7 is next. We'll do that next week. That is the last chapter on the next exam, and it's a short chapter. 5, 6, and 7. Any questions? No? Alrighty. Okay, we're on the